para, okay? Then centesis. Whenever they say there is centesis, you're removing some fluid, okay? Removing some fluid. The para portion referred to the peritoneum layer, okay? And so this is going to the abdomen, and then you're trying to remove some fluid from the individual. Probably they have ascites, and that's all. That's what you're doing based on the name. The name give you the idea. So paracentesis is basically you're going into the peritoneal cavity to remove some fluid. This is temporary. It's not permanent. So you're just basically trying to temporize a situation that is getting bad. You can't do this procedure without a consent. Of course, you are not responsible for the consent. You just witness it. That's all. You make sure, and your witness means, all it means is patient understand the procedure and does not have any more questions. And everything is being explained to them. The risks and benefit has been explained. So that's all. So you just witness that. You are not responsible for the consent, but you want to make sure that there's a consent before the procedure. You got to make sure this is very important. So they have to void before the procedure so that the bladder is not injured. Which position are they going to be? The position is very important. They can be in a high Fowler position. That is like 90 degrees. Upright, so they can be in a upright position with the arm, basically the arm over a table. In that, the patient usually in that position before the procedure. Okay, that's where they will be, and that's how they will be after the when the procedure is done. Okay, after the procedure, all you need to do is assess the abdominal girth, the diameter, because they have ascites, so the abdomen is like distended, and so you check how much decrease in size has occurred, and then you got to check their vitals. Okay, you have to pay attention. All the fluid that they have is in their abdomen. If you remove it, they become hypovolemic. They're already hypovolemic, even though they have ascites, because the fluid is in the abdomen. If you do that, they'll become hypovolemic after the procedure. And so you got to watch for hypotension and headache and dizziness. What do? Do you give them fluid? No fluid. You give them albumin. So albumin, 5% is okay. So they need some albumin because either 3% or 5% is fine, or 20%, whatever you have. But these people, if you give them fluid, they will cause more ascites. The reason why they have ascites is because they lack protein. They don't have albumin, and so their oncotic pressure is very low. So when they develop ascites, if they need any fluid, the most likely fluid is not isotonic fluid or this thing. You give them albumin as the source of to help improve their oncotic pressure. And that is that portion of it, paracentesis. What you need to do and what's the requirement, and then what you need to follow after the procedure. That's all. Lumbar puncture. This is usually done to collect the CSF to evaluate for like a meningitis. You cannot do this without head CT scan. You need a head CT scan to rule out mass or brain lesion. Do that. Otherwise, they have brain herniation. So this is a contraindication. But before any lumbar puncture, patient need a head CT scan. Very, very important. That's number one. You got to do that. This thing you need a consent. You You make sure there's a consent, you witness it, okay? You let them empty their bladder, the same thing, because they're going to lay flat. So let them empty their bladder as much as possible. And because of the location where we put this in the L3, L4, in the lumbar area. So let them empty their bladder. And then which position are they going to lay? Side laying. With the knee, their knee drawn up. Okay. Or they can be in a sitting position, sit up like the way the paracentesis is done. They can sit up and then bend over a table or forward. So those two procedures is fine. We prefer laying on your side with the knee drawn to your belly, basically like a fetal position, because if you sit, if you sit up and you bend over, the nurse has to hold you, the nurse has to stabilize them so that they don't move. So you got to be careful. If they give you a question and patient is sitting up and bending over for lumbar puncture, it's your responsibility to make sure they don't move. So you hold them, you keep them, you distract them from the needle, and then they will embrace you. So you will be the way to distract them. Okay, very important. And like you say, it's done L3, L4. After the procedure, so after procedure, so we got to put pressure on where the leak will be coming from. Therefore, they remain supine. They have to remain supine for 4 hours, at least 4 hours. By their head of the bed is greater than 30 degrees. So you can still be supine, but your head is so you can raise the head up, but the whole bed is flat. So supine for 30 and for 4 hours, but the head, your head has to be and above 30. This is to prevent headache, common symptoms. So if they give you a question, somebody had a lumbar puncture and they have headache after the procedure, it's okay. Don't worry about it. We just need to let them drink some fluid, treatment, some fluid, or you can give it an IV fluid, okay? And that will help with that. So that's all. Fluid is the best way to do that. If the leak doesn't seal and it continue to leak, then we do something we call blood patch. And we use the blood patch to close the leak. But most of the time, laying flat, head raised up 30 degrees will help with the situation. And then you give them fluid. Because of that, before the procedure, you let them hydrate themselves also, or after the procedure, you tell them to keep on drinking because you're going to get a headache. And then if you drink more, the headache is less pronounced. Okay, so this is the first two procedures. So your liver is on your right upper quadrant. So this is your diaphragm, your belly button, your liver is here on the right side, right upper quadrant. Okay, and so when we have to do this liver biopsy, you can just lay supine. And we can go there and then use a needle and then take a biopsy. Supine, we go there, take a biopsy. After the biopsy, we got to put pressure here. We can put pressure with our hand. Gauze cannot put pressure. So after the procedure, you have to put the patient on the right side. So after procedure, right side. Down. So that area down, that will put pressure there and that will prevent bleeding. The liver is a vascular organ, very vascular, that receives all the blood from the lower extremities and the abdomen and send it to the heart through the IVC, inferior vena cava. So if you stick the liver and you don't apply pressure, we're bleeding. Will happen. Bleeding, bleeding, bleeding. So after the procedure, your job then is to watch for bleeding, prevent bleeding. So put them on the right side. So the right side is down. So they will be, the right side will be on the bed and the left side will be up. So right side down. So right side down. Once again, right side down. Then you watch for bleeding. How do you do that? Urine output. Okay, heart rate, blood pressure, dizziness, change in mental status. Okay, if they give you lab, H&H will go down. BUN up. Creatinine up. Right? All these things they can give you and trying to deceive you, but basically they're telling you patient's bleeding. Liver biopsy, low urine output, bleeding. Liver biopsy, heart rate high, bleeding. Liver biopsy, blood pressure low, bleeding. Dizziness, bleeding. Diaphoresis, bleeding. Change in mental status, bleeding. H&H low, bleeding. BUN greater than 20, patient is bleeding. Creatinine more than 1 is bleeding. Hypovolemia. So that's the way they will set the question. And that's, so if they give you 4 patients, who do you see? Liver biopsy patient, and they are laying on their left side. So left side, or supine, or prone. You got to check. You got to be sharp. This is B sharp movement. I need to see this patient. They bleeding. So that's the key for that particular aspect of it. It's on the left side. Kidney is here. Is the diaphragm. There's another one here. Left and right. Okay, there's 2. And the bladder go here like that. So it's at the back. Okay, it's on the left and right. So, but it's at the back side, all the way to your back. We call it retroperitoneum. So we can get access to that. So to biopsy it, the best way to biopsy is to lay prone, face down. It's also a vascular organ. It has like about 20% of your blood volume. So that's how much you receive. So if you stick it, it's going to bleed your blood pressure. Otherwise, they will bleed to death. I forget about the liver. Because they're going to bleed, what do you think you need to do before the procedure? Stop NSAID. It's the same thing. I forget about it. NSAID, most of the time, I'm just saying from my head. NSAID, stop it. If they take aspirin, stop it. If they take Coumadin, stop it. If they take heparin, stop it. Any anticoagulation. And then what? Check their CBC before the procedure. Check their PT, T, INR, all of them before the procedure. Check their platelet, which you can get from the CBC. And these will give you, so that when they're bleeding post-op, you know that something is going on. After the procedure, I need to put pressure. How can you put pressure on your back? How can you do that? Like the lumbar puncture patient. Yeah, after procedure, put pressure. Let them lay supine to prevent bleeding. Therefore, any patient after kidney biopsy and is laying prone, laying on the left side, laying on the right side, upright, walking, guess what? We have a problem. B sharp. I got to see you. This and the liver, kidney, they need to be down for 2 to 4 hours on the side, laying supine on the side, but they have to be bed rest between 12 to 24 hours. So very, very important. Liver, kidney, the side that was punctured has to be down for 2 to 4 hours. Then after that too, they have to be at bed rest 12 to 24 hours. So it's very important to prevent bleeding. Same thing. If they give you liver kidney biopsy, heart rate high, bleeding, blood pressure low, bleeding, urine output low, bleeding, BUN high, bleeding, creatinine increase, bleeding, dizziness, they are bleeding, diaphoretic, they're bleeding. What have you? Any signs of hemorrhage, bleeding. You're not going to see it. I just left it there. Now let's come to where they will trick you. Both the liver and the kidney, if you see frank ecchymosis, is bleeding. If you see periumbilical ecchymosis, bleeding, both of them. So in this sign, I just left them together so that I can put them together. So Kellen sign is the umbilicus. If you see, they tell you, oh, liver biopsy, there's some small bruising on the umbilical area. They're trapping you. Yes, you got to see that patient. They'll use the word small bruising, okay? And he said, and this is the great tenor, hey, there's small bruising on the frank, both sides. Yes, go see that patient. They're bleeding, hemorrhage. So those two signs are very specific for this. The same thing as pancreatitis, they can do that too. But these are some of the signs you got to pay attention to. Okay, thoracentesis, right? Same thing that we saw, para. This is thora, is thoracic, your chest. Centesis, removing fluid from your chest. So this is you. Your lungs are here. Your heart is here. Diaphragm is here. And so we want to remove fluid in here. The best position to remove fluid is on the dependent position. So you let them be in the dependent position so that the fluid can collect over here. There's no space here. If you let them lay flat, sometimes you can let them lay flat, but this is the best position. You don't want to stick the lung, you don't want to stick the heart. So when they lay upright, yeah, upright position is the best way to do the procedure. So upright. This will provide some gravity. And then they have to put their hand basically stretched on the on something on the table, like the same thing as the paracentesis. It's the same thing. They can be supine though, but hardly do we use that position. But some people cannot lay it, and they have to be supine, and you got to be careful. But that's not the best position. Okay, the best position is upright. And then you remove your fluid. You come with your needle and you poke them here and you take your fluid out and go do your analysis. After the procedure, post-procedure, even though it's a small needle, do you want that side to be on the bed? No, because now you've created something that their body doesn't like and they will have problem breathing. You want that lung to expand. So you don't do that. After the procedure, you place them on the, well, which side do you want to put them? Unaffected side. So unaffected side. So they lay on the unaffected side and the affected side is up so that that lung can expand and get better. They may trap you. Okay, these are keywords. You see subcutaneous emphysema. All it means is some spongy feeling. You put your hand here and you feel like mattress, spongy feeling. The air has escaped into the skin and the whole place feel like spongy feeling. It means they have pneumothorax, okay? Okay, it means they may have pneumothorax. That spongy feeling on the skin. If that happens, they've developed pneumothorax. So you got to watch them, okay? Pneumothorax. A thoracentesis, what do you watch them for? Yeah, this. Watch them for pneumothorax. And how would you know they have pneumothorax? They will have subcutaneous emphysema, or they will become symptomatic. They will start having shortness of breath, or diaphoretic. What is your treatment? They get a chest tube. And if they get a chest tube, well, you got to know how to put it in. How will you put it in? They have to lay supine, okay? They will lay supine for the chest tube. Supine for the chest tube. And if it's the left side, the hand has to go behind the head. So they'll put it behind the head, like how you put your palm behind your head so that you can get access to the whole flank area. So supine on the left or right behind the head so that you can do the procedure. After the chest tube, yeah, they can just be supine. You don't need to put them right side up, you know, depending on the unaffected side and up, I mean, down anymore. So after you just keep them, after procedure, keep them just supine. The chest tube, because the chest tube is now taking care of the pneumothorax. They can't develop two pneumothorax anymore. The reason why when you do the thoracentesis, you put a needle there and you take it out, you've created pneumothorax. And so in order to prevent further trouble breathing, you put them on the unaffected side so that the affected side is up and can expand. Now I've taken care of it, put a chest tube there. I don't need to put them on the unaffected side. I can just put it in supine and both lung can expand. That's something you have to understand it. Okay. And so that is the way to do thoracentesis. This is chest tube. Sometimes the chest tube, they will write tube is the same thing, tube thoracostomy, you know, and I need to show you so that in case you see it, you don't freak out. Ostomy is a hole, right? We already know. Colostomy, gastrostomy, urostomy, tube going to somewhere, to the chest, thoracic, tube going into the thoracic through a hole. That's all. That's what chest tube is. So if they give you tube thoracostomy, it means chest tube. If they give you thoracentesis, it means you put in a needle to take fluid out. If you put in a tube to take the fluid out, it becomes tube thoracostomy. That's chest tube. Okay. There's few ones that you got to pay attention to. Sometimes they'll give you, patient need a eardrops. Okay. What do you do? Which position you want to put them? When you put in a eardrops, think about it. Okay. I want to put a eardrops. I want the drops to go into your ear. Okay. So with the affected side has to be up and they have to lay on their side. So with the affected side up. So if your right ear is the problem, the right ear has to be up, but you have to be on your side so that when I put the drop on the side without any problem. Okay, so that's in another position. But if I'm irrigating, I don't want the water to go into your eardrums. So it's the opposite, right? Irrigation is different. The affected side down, still side laying, because I want the water to go and come out, come out. I don't want it to go into your eardrum. And then if you have to give them eye drops, I think it's the same. Okay. Usually it's different. I mean, everybody have the way we do it at home. You can be supine or you can be sitting down. It's fine. But your head tilted back. Okay. And you should be facing the affected side. If my right here, so my head tilted back, but rotated towards the affected side, so that when you put a drop, it can go all the way along both the conjunctiva and so that you can get a good effect. But it's turned towards the affected side. So these are quick stuff just to get you guys going. There's some conditions, okay, that when it happens, you got to put the patient in certain position, right? So if patient has what? Air embolism, and you should be able to figure it out. In the next generation, they're not going to tell you. They will give you a patient that's an IV, the next went to go pull the IV, all of a sudden, shortness of breath, tachycardia, SAT is decreasing. What do you think? I pull an IV and you have this, I've not done anything to you, air embolism, classic symptoms. So you have to learn how to remember these signs and symptoms and put it to the scenario. So sudden onset of shortness of breath, okay, feeling of doom, okay, SATs going down, respiratory rate up, blood pressure going down. Yeah, they have air embolism after pulling IV. That's all. Air escaped into that. Therefore, what is the position you put them in when this happens? Right away. Head down. So T-bag, Trandelebeg, I call it T-bag, Trandelebeg, right? Head down and the left side down. And then the doctor will come in, put a needle, aspirate, or it will evacuate slowly. But there's nothing we can do. It's supportive care. And that is what you do when that happens. How to prevent it. If they ask you a question, they can also ask you, how do you prevent embolism? What do? When you pull in the IV, make sure patient is supine. Supine as much as possible. Supine. That is the best way to prevent that position. You don't pull IV when the patient is sitting up. You don't pull IV when they are 95 Fowler position. Supine to prevent embolism. And BK. When you do amputation, we want to avoid flexure contractions. Okay, because of that, after 24 hours, they need to be prone 30 minutes, 3 to 4 times a day. That's how you can prevent it. Okay, drooling, dysphonia, distressed airway, okay, and desaturation. What do you think? 4 Ds. Epiglottitis. See them in tripod, keep them there. Don't make them move. Don't make them change their position. They're telling you they're dying. And you should not examine them. Examination is no, because the tripod is your examination. If I'm in the tripod position, I'm telling you, nurse, I'm dying. Don't put anything in my mouth and don't do anything. Just give me oxygen. Keep me there. And what is that? They will sit in a chair, okay? and they will lean forward. They will describe it. If they describe it, that's what they mean. Kids sitting in the chair, leaning forward. I was going to do a next generation question like that to see if people understand how to make differential diagnosis and then diagnose and treat them. Kid is leaning forward, okay, sitting down in the chair, okay, their hand is on their waist, just putting on their waist that like that to help them, or rest in their knee, okay, arm and elbow resting on the knee. That's what we mean by tripod position. Same thing, 1-year-old crying, I'm intentionally doing this, crying, mad, and turning blue. He has congenital heart disease. What do you think? Arthritis or falling? Which position do you put them? Knee to chest. In the knee chest position to decrease the amount of shunt, and that will help with that. Rheumatoid arthritis, we talked about it yesterday. What do you tell them? How do you want them to lay down? In neutral position as much as possible. So you should sleep on a flat, hard mattress. That's what you tell them. Okay. Knee, or let's do hip replacement yesterday. Where do you want to put this patient? First up, you should avoid adhesion. Avoid adduction and flexion. So what do you use? Abductor wedge in between their legs. You can use pillows, and then they should not bend more than 90 degrees, at 60 degrees. But you can go up to 90 when you're sitting down, but don't go past it. But I tell them don't bend more than 60. If you're sitting up, yeah. So let me say it. If you sitting up, sitting, when you're sitting up like that, don't pass 90. If you're trying to bend, don't bend more than 60. So don't pick anything on the floor. You should not pick anything on the floor. You cannot go to sit in your tub. No way. This patient, they can't do tub washing. The toilet seat, you need a higher one. This is the quick review. Okay, so you got to modify everything. And then you saw a deceleration, and then you see a cord is coming out, prolapse. Yeah, what do you think? Knee to chest position. Baby is coming, and you saw a turtle sign. What is that? The baby head come up, and it sneak back. Back and forth, back and forth. We have what? Shoulder, start here. What do you do? Knee to abdomen and suprapubic pressure. I'm just giving you some of the key, the things that they like to test you on. You put pressure on the suprapubic area, and then you time. Time is your factor. Time is number one. As soon as you see that happen, time. Otherwise, the baby is going to be hypoxic. So we got to fix it as much as possible. And these are just like quick review so far.